Welcome to PBH 275, Injury Prevention and Control. This video topic is about abuse-related injuries in two uniquely vulnerable populations, children and senior citizens. This lecture is going to cover the unique vulnerabilities of children and the elderly to particular injuries. In this case, we're going to talk about injuries related to abuse and neglect. We're also going to be talking some today about emotional injuries, which can be just as damaging as physical injuries. And in this injury prevention and control course, not every injury we talk about is going to be a physical injury. And today we will cover some cases of emotional injuries as well. For child maltreatment and neglect, we're going to go over the epidemiology of it and also some evidence-based preventions at different stages of childhood that have worked, that have been shown to work. We're going to briefly cover adverse childhood experiences, which those of you that are public health majors have probably already had that covered in other courses, so we won't spend a lot of time on it, but I will touch upon how adverse childhood experiences can sometimes predict not so good health outcomes later in life. And then on the other end of the age spectrum, we'll talk about elder abuse, its epidemiology, and some preventive strategies for it. Infants, children, and the elderly have unique vulnerabilities that make them more susceptible to injuries when compared to the non-elderly adult population. One of these reasons is that certainly this is the case with infants, and it can also be the case with elderly persons, particularly if they've suffered a debilitating stroke or in advanced stages of dementia. They can be nonverbal, so that they don't have a way to express with words whenever they are feeling distressed or when bad things are happening to them. There's also a dependence on caregivers. And when you're dependent on caregivers, that means that sometimes the emotional and mental state of the caregiver can be manifested in the person under their care if their emotional and mental state is not particularly good. Certainly, if you're a very young child or an infant, or you're an elderly person dependent on caregivers, you have limited autonomy, and you're very vulnerable to circumstances. There's also some physiological reasons for increased injury risk at these stages in life. If we look at infants, first of all, whenever an infant is born, for the first several months of life, they have what's called fontanelles, these soft cartilage spots on their skulls. That enables the skull to compress a little bit during the process of going through the birth canal. And over a few months to like a year, as the infant ages into a toddler, those fontanelles start to harden up and turn into bone. But there's soft spots on other parts of the skeletal system as well in infants that don't exist later in life, and that make it a little bit more susceptible to injury. When we talk about elderly persons, there can certainly be balance and vestibular issues that make it more likely that somebody can fall if pushed slightly, for example. Bone fractures are more frequent as we get older because of osteoporosis and other bone weakening diseases. And our ligaments and tendons also become more delicate because they, unlike our bones, they can actually get calcified as they get older and become more brittle and more susceptible to rupture as a result of an injury event that maybe when at a younger stage of life would not really be debilitating. So this is why these are populations that are uniquely susceptible to injuries being inflicted either unintentionally or intentionally. Before I begin talking about child maltreatment and neglect, I want to provide a content warning right here and now. The information in this next section could be very difficult to hear if you're an adult survivor of child abuse, maltreatment, or neglect. If you are an adult survivor of child abuse or neglect and you need to talk to someone, just know that the Crisis Support Services of Nevada is available 24 hours a day, 7 days a week. You can call or text 988 and reach out to somebody who can talk to you about this. The official definition of child maltreatment for legal purposes can vary from state to state. In the next slide, I'll show you the Department of Health and Human Services' current definition for child abuse and maltreatment. A very important federal act was the Child Abuse Prevention and Treatment Act, or CAPTA. What CAPTA has done is provide minimum standards for defining what is physical child abuse, child neglect, and sexual abuse. And then if you're a state that wants to receive federal funds, you have to incorporate into your state laws statutory definitions of how you define child abuse, child neglect, and sexual abuse. So it might vary from state to state, but it has to be sort of within the parameters of what the Department of Health and Human Services at the federal level says it must be if you want to continue to receive federal funds. CAPTA has been amended a couple times in recent years to add additional protections to certain classes of children. It was amended in 2015 to include protection for childhood victims of sex trafficking, and then in response to the opioid epidemic in the year 2017, CAPTA was amended to include special protections and provisions for infants born addicted to substances as a result of in utero exposures to opioids or other drugs. The U.S. Department of Health and Human Services defines child abuse and neglect together because it's actions that are taken that cause harm, but also failure to act in certain ways that leads to harm. And so this definition includes both abuse and neglect. And the official definition is any recent act or failure to act on the part of a parent or caretaker which results in death, serious physical or emotional harm, sexual abuse, or exploitation. What's interesting too is the other way that they define child abuse and neglect, which is an act or failure to act that presents an imminent risk of serious harm. This is interesting because if you put a child in a dangerous situation, even if they don't ultimately get harmed from it, that can still, by the strictest definition of the DHHS, can be considered child abuse and neglect. If you're a caregiver of a child and you have them riding in the back of a pickup truck, for example, in the bed of a pickup truck at road speeds, even if the child wants to do it, if they think it's fun, there's such an imminent risk of serious harm by doing that just the very act of having a child ride in the back bed of a pickup truck at highway speeds could be considered child abuse and neglect. And it is in many jurisdictions, and that's part of the reason why you don't really see that anymore. Not like you did when I was a child. Child maltreatment certainly has a physical toll and an emotional toll on both individuals and on society. But there's also a monetary cost that comes with it. There's been some efforts made to estimate how much monetarily that child maltreatment is costing our society. And back in 2015, Peterson and colleagues did a study on this economic burden, and they came up with a total lifetime cost in a calendar year to be about $428 billion. If you're wondering how many child maltreatment referrals are happening in a given year in the U.S., for the most recent year we have data available, there were 4.36 million referrals received by state and local agencies. This covered 7.7 million children because some of the referrals were in multi-child households. That averages out to a little bit more than 8 referrals every minute. Now, fortunately, not every single referral is found to be an actual case of child maltreatment. About 12% of all referrals in the most recent year actually led to documented cases of abuse or neglect. If you want to know what that victimization rate is for the entire population, it's a victimization rate of 7.2 victims of abuse or neglect per 1,000 children. One of the most important things that CAPTA does is it requires every state to designate mandatory reporters for all known and suspected cases of child abuse and neglect. And so every state has done that, including Nevada. Here in Nevada, we have a large swath of mandatory reporters. These are people who, maybe because of their profession or what they do, they're in position to interact with children and with caregivers and can maybe recognize some of the signs and symptoms of abuse and neglect. So here in Nevada, pretty much everybody that works in the medical field, certainly physicians and nurses and psychologists, therapists, social workers, and counselors, they're all mandatory reporters, as are the coroners. If the coroner's office suspects that abuse or neglect might have been part of a cause of death for a child or for an elderly person, as it turns out, we talked about that briefly earlier, that has to be reported. All members of the clergy are mandatory reporters, as are all employees of public or private schools. And not just employees, if you're a volunteer serving at one of these schools and you encounter a situation that you think or suspect might be child abuse and neglect, you're a mandatory reporter. Everybody that works in law enforcement is a mandatory reporter, and not just the sworn law enforcement agents either, but members of the court, members of the clerks, all sorts of other positions within law enforcement, and also attorneys are mandatory reporters. So there's a very large number of mandatory reporters in Nevada, including, in a lot of cases, university faculty. I'm a mandatory reporter for all known and suspected instances of child abuse and neglect. So mandatory reporting system to the state and local authorities who investigate and can do something about if it's found to be a true case of abuse and neglect. It's a very powerful tool. Like a lot of other public health issues that have been covered in this class and that will be covered in future modules, there are some pretty profound disparities in the burden of child maltreatment across various demographic categories. The rates are very high for children under 1 year old, which that makes sense if you think about it. You're dealing with for the most part, nonverbal child who only knows how to express their concerns in one way, which is crying, and an inexperienced caregiver or parent. And that's when a lot of maltreatment occurs, unfortunately. Children of low-income families are more likely to suffer maltreatment, as are children who are in single-parent households or where there's a non-biological caregiver in the home. Lower parental education level is also associated with increased risk, as well as a parental history of being a victim of child abuse. And it will probably not surprise you to know that one of the main predictors of child maltreatment is if there's a history of intimate partner violence in the home. If the caregiver and their intimate partner have a history of violence, either one way or two way, that's often is a predictor for child maltreatment. This type of abuse can take many forms. Physical abuse, neglect, and sexual abuse and exploitation are probably the ones that are most likely to actually result in physical injuries. And this is an injury prevention and control class that you're in right now. So these other forms of abuse, I mean, some of them, they might not necessarily leave physical injuries. Certainly parental substance abuse can cause physical injuries, especially when it happens in utero. But even if it happens to a child after they're born, it can create a dangerous environment for a child where injuries are more likely. But yeah, we're going to talk about all these types, even though some of them might venture out a little bit beyond the scope of, prevention of physical injuries the way we normally think of them. Certainly, emotional injuries can be just as damaging. Emotional abuse can certainly, as we'll talk about later with adverse childhood experiences, can actually lead to physical outcomes later in life that are negative. And then abandonment, which is kind of also a form of neglect. We'll talk about these types in a little bit greater detail. Physical abuse and neglect are the two categories of abuse which are most likely to lead to child fatalities. When we look at the most recent year of data from the U.S. Department of Health and Human Services that periodically publishes their child maltreatment report, what we find is that when we're looking at the total population of children who died in that year as a result of documented abuse or neglect, 65.7% of child abuse fatality victims were under the age of 3. What surprises a lot of people to learn is that it's often not the actual act of physical abuse that proves fatal to a child. It's failure to do something that a child needed in order to thrive or even survive. In other words, neglect is more often the actual cause of these types of deaths. In this case, neglect was present in more than 4 out of every 5 child fatality cases in the year 2024, 84.6% of all of them. Whereas physical abuse was present in 39.9% of these child fatality cases, so about 2 out of every 5. So yes, we do not want to underestimate the prevalence and the severity and the public health challenge of physical abuse, but what actually is leading to more fatalities is the failure to act, neglect, failure to provide what children need in order to survive and thrive. There's also a gender identity-based difference in victims of child abuse and neglect, and the male children represent 58.3% of child abuse fatalities. What the child maltreatment report also shows us is that another demographic fact is that physical abuse death rates tend to go down as children get older. This makes sense if you think about it. As children become older, they become stronger, they become more independent, they become more able to verbalize opposition and actually speak up for themselves. Plus, as children get older, especially as they enter into the adolescence era, power dynamics change, and children start to develop a sense of independence, and they actually become physically stronger, and in some cases they actually start to fight back against abusive behavior. So as you can see from this exhibit from the 2024 child maltreatment report, the rate of child fatalities per 100,000 is very high under the age of 1, but then you see from ages 1 on all the way to 17, it's just generally trends in a downward direction. So now let's talk a little bit more about child neglect, which, as I just mentioned before, was found to be present in 80% of all child maltreatment fatality cases. What do we mean when we use this term? We can mean a lot of different things. Physical neglect is probably the easiest one to understand. This would mean that you abandon a child and don't actually provide any guidance, you don't provide any care to them. Expulsion is sort of like that, but this often happens when a child gets a little bit older. This would be where you blatantly refuse to have the child in your home. You actually physically throw them out of your home and then do not permit them to come back into your custody. That would be considered expulsion. Like if you have an adolescent child that runs away and then they decide to come back home, even if you're upset with them, you cannot force them to stay out of the home if they come back. That would be considered expulsion, which is a form of physical neglect. Shuttling means that a child is sort of passed around between different caregivers who might not know what they're doing or who might present dangers in lots of different ways. Nutritional neglect is exactly what you think it means. It means that you don't provide for the nutritional needs of a child, particularly during their times when they're growing and their nutritional needs can be vast. The same with clothing neglect, where you're not providing for the clothing needs of a child. That's considered a form of physical neglect. Medical neglect occurs when you deny health care to a child that needs it. There are some religious exemptions for denial of health care, particularly when it comes to things such as vaccinations or blood transfusions. But in these cases, there has to be a well-documented religious exemption. It can't just be something that's made up real quickly because you don't want to take your child to the ER, when they need it. And delays in healthcare. If a child breaks a bone and needs to have it set, and for whatever reason, maybe it's lack of insurance, maybe it's not being close to a ER, or maybe it's just apathy. If you delay healthcare for a child who needs it, so that, for example, that bone doesn't grow back right, that would be an example of medical neglect. Educational neglect means that that if you're a parent or caregiver, you don't send your kid to school, or you permit chronic truancy. You don't enroll them in school. Or if a child has a special educational need, you fail to pay attention to it or to do anything about it so that they're unable to learn. Emotional neglect, that basically means inadequate nurturing or affection, where you just do not respond to a child in a way that meets their emotional needs. If you permit drug or alcohol use for children, if they're taking drugs or drinking and they're not of age to do either of those things, or they're using an illicit substance, that's considered, besides it being a physical neglect, that would also be considered emotional neglect. Or if you permit other maladaptive behaviors, if you refuse psychological care when a child clearly needs it, or delay psychological care. If you isolate a child, if you don't let them play with friends or really see other kids, and they don't develop social skills, that's considered a form of emotional neglect. Another form of child neglect that's kind of in recent decades has become more prevalent is inadequate supervision. This is something that maybe when I was a kid was probably happened a lot more, but now society is thankfully less tolerant of it, where you leave a child unsupervised for long periods of time. Because a child unsupervised can be exposed to lots of hazards that if an attentive parent or caregiver was there, they would not be exposed to. And then inappropriate caregivers. If you have a very young, if you have a very small child who's being watched over by a 10-year-old sibling, that would be considered an inappropriate caregiver. That's a 10-year-old older sibling or cousin or something like that is not prepared to give the kind of supervision that's needed to ensure that injuries do not occur. And then as of the year 2017, newborns born addicted or exposed to drugs, that is also considered a form of child neglect, for which charges can be brought and also custody can be lost of a child. So I talked in the last slide about emotional neglect, but there's another thing that can happen to a child, which is psychological maltreatment, which is actually termed emotional abuse. This is a repeated pattern of caregiver behavior or extreme incidents that convey to children that they are worthless, flawed, unloved, unwanted, endangered, or only of value in meeting another's needs. This definition of emotional abuse or psychological maltreatment comes from Hart and Brassard. This can take a few different forms, one of which would be spurning. This is where a child is ridiculed, they're hostilely rejected, and maybe turned out of the house overnight as a form of punishment, would be an example of this, or repeatedly belittled. Terrorizing. This means that it doesn't necessarily mean that violence occurs against a child, but that violence is repeatedly threatened against a child, or a child is repeatedly placed in a recognizably dangerous situation that's meant to make them feel terror. And then isolating is another form of emotional abuse. And we kind of talked about that in the last slide too, as a form of neglect, where you confine a child, you place unreasonable limitations on their freedom of movement, you restrict them from social interactions. This can just have devastating effects on child development. Many years ago in the state of California, there was a case of a young girl named Jeannie Wiley, and she was basically raised without any human contact. She basically was feral. She was never sent to school. She was never given medical treatment. She never interacted with other people. She was just kept confined in an isolated corner of her family's property, and it wound up having absolutely devastating consequences on her emotional, psychological development, and just in everything. From what I understand, she's still alive, but nobody has heard from Jeannie in several years now, and the the abuse that she suffered, and just from this psychological maltreatment, it's kind of hard to imagine. Other forms of emotional abuse can include exploiting or corrupting. An example of this would be modeling antisocial behavior, such as criminal activities. If you're a parent or caregiver and you train your child to help you in, for example, the commission of robberies or other crimes like that, that would be an example of exploiting or corrupting, as would be encouraging prostitution or permitting substance abuse. If you, that would be exploiting or corrupting to allow a child to have access to alcohol, cocaine, methamphetamine, anything like that. Denying emotional responsiveness is a form of emotional abuse where you ignore the child's attempts to interact, you fail to express affection, you just basically, when children want to interact and want to express affection and they get sort of rejected like this, it can teach children to not express these parts of them and not develop them, and that's a devastating form of emotional abuse and can actually lead to physical symptoms later on in life. And of course, mental health, medical, and educational neglect. Kind of talked about that before with the case of Jeannie, but also just anytime you fail to provide treatment for serious mental health or medical problems, or just ignore the need for services or for serious educational needs. This is not just neglect, it's also emotional abuse, which can lead to later physical injuries, as we'll talk about shortly. At this point in your public health or medical education, you've probably been made aware of the Adverse Childhood Experiences Study and Adverse Childhood Experiences themselves, or ACEs. I'm going to talk a lot about this study because it was a really important foundational study in the investigation of how experiences people have in childhood, they can carry with them to later in life, and it can impact individual health. And of course, if a lot of people have adverse childhood experiences and it affects a lot of individual health, it can have an effect on population health. So the ACE study, the original ACE study, started in 1998. It was one of the largest investigations ever conducted to assess the associations between childhood maltreatment and later life health and well-being. And the initial study results of the ACE study were published in 1998, but the cohort continues to be studied to the present day and probably will be for many years to come. The ACE study was a collaboration, and is a collaboration, between the Centers for Disease Control, Prevention, and the Kaiser Permanente Health Appraisal Clinic in San Diego, California. There are more than 17,000 study participants. The findings of the initial Adverse Childhood Experience study was that certain adverse experiences in childhood are major risk factors for leading causes of illness, death, and poor quality of life later in life. And what happened is these subjects that were enrolled, they were given a physical, and then they were given a questionnaire, and they actually would self-report whether they'd had certain negative experiences in their childhood. So that is one of the recognized limitations of the ACEs study. It's a self-report study relying on self-report data. But the questionnaires were designed in such a way as to get honest responses from people, and subsequent studies have shown that the ACEs study tools were built pretty well, and that, yeah, we can trust the findings. If we're going to have better public health in this country, we have to recognize the connections between adverse childhood experiences and later in life, negative health outcomes, mental and physical health outcomes. So if you're wondering what are these adverse childhood experiences that were part of that original study, the original 10 ACEs were the following: recurrent physical abuse, recurrent emotional abuse. And again, just remember, these were all self-reported by the 17,000 plus study participants. They chose to report on these, and so we're all very grateful for their being willing to to go back there and talk about these things, because I'm sure it was not easy to talk about them. But again, recurrent physical abuse, recurrent emotional abuse, sexual abuse did not have to be recurrent. If it happened even one single time, that was considered an adverse childhood experience. If there was an alcohol and/or drug abuser in the household, if there was a household member who was incarcerated during the time when the subject was a child, if there was someone in the household who was chronically depressed, mentally ill, institutionalized, or expressed suicidal ideation, if they had grown up in a household where the mother was treated violently by an intimate partner or anybody else in the household, if parents were separated or divorced, or if there was emotional neglect or physical neglect based on some specific questions that were asked about if these experiences happened to you in your childhood, and if a certain number of boxes were checked, they were deemed to have had emotional or physical neglect in their childhood and that adverse childhood experience. The original ACE study looked at sort of individual and familial level adverse childhood experiences. Some subsequent ACE studies have considered additional adverse childhood experiences at a community level. One example would be the Philadelphia ACE study, which expanded their ACE questionnaire to include some community-level adverse childhood experiences, such as the following. Did you ever witness violence in your neighborhood? In other words, we're not talking about in your household, we're talking about in your community where you grew up. Did you ever know somebody who got beaten up, stabbed, or shot in real life? If you ever felt discrimination while you were growing up, if you felt like you were being treated badly or unfairly by people outside your household because of your race or ethnicity? If you ever had any adverse neighborhood experiences, such as not feeling safe in your neighborhood, not feeling like people in your neighborhood were looking out for each other, or that they could be trusted, that was considered a community level ACE. If you ever got bullied outside of the household in other situations, such as in school by a peer or a classmate, that would be considered a community level ACE, as would living and being part of the foster care system. There are more than 40 negative health outcomes for which adverse childhood experiences have been shown to show a graded dose-response relationship. In other words, the more ACEs you have in childhood, the more likely it is that one of these negative health outcomes is going to occur. What I want you to keep in mind with these, though, is that if you've had adverse childhood experiences, it might increase your likelihood for some of these negative things, but it's not perfectly predictive. This is population level data. This is not intended to predict the outcomes of any one person's life based on what happened to them early in life. So please just keep that caveat in mind. This is population level data. But what the population level data shows us is that as ACE's score goes up, so does the risk for risky behaviors, such as physical inactivity, smoking, abuse of alcohol and drugs, and early sexual activity. As the ACEs score goes up, so does the risk for chronic diseases such as obesity, chronic obstructive pulmonary disease, asthma, diabetes, liver disease, and heart disease. And the risk for other negative health outcomes also goes up as you have more adverse childhood experiences, again at a population level. And these other negative health outcomes include teen pregnancy, sexually transmitted diseases, miscarriage, depression, suicide attempts, early death, lost time from work or trouble holding a job, and perpetration of intimate partner violence. But again, just please, let me be clear on this. Having adverse childhood experiences does not mean any of these things are going to happen or that you're going to suffer from these or perpetrate any of these. It's just there's a population level, predictive exercise. That's all it is. While adverse childhood experiences do not predict outcomes for individual people, we do know that on a population level, ACEs can have lasting effects on behavior and health, that childhood experiences can have a tremendous lifelong impact on our health and quality of life. What the ACE study showed us is that there's a dramatic link between these adverse childhood experiences and risky behavior, psychological and mental health issues, serious illnesses, and some of the leading causes of death. This bubble graph here shows you that you look at people that have an ACE score of 0, and then you look at the different sizes of the bubbles, depending on if you've had 1, 2, 3, or 4 adverse childhood experiences. The risk for not engaging in physical activity, for being a chronic smoker or chronic alcoholism, having severe obesity, diabetes, depression, and physical and mental health outcomes, suicide attempts, that as your ACE score goes up, the risks at a population level of all these things go up as well. If you're wondering, how common are adverse childhood experiences in the population here in the United States? Again, this is based on self-report data from several ACE studies, but about 64% of all people surveyed in the US have experienced at least one adverse childhood experience. Only 36% of respondents self-reported having 0 adverse childhood experiences. 12.5% of the population, that's 1 out of every 8, based on the survey data. Again, self-reported survey data, but still, that's still a very substantial proportion though. 1 out of every 8 surveyed population reported having 4 or more adverse childhood experiences. So you can see this is a really big problem we have in public health and mental health and emotional health here in the United States. So we have covered a lot of grim statistics and information about child abuse and neglect and endangerment. So now let's shift our focus a little bit to prevention. Prevention programs have traditionally focused on education for individuals as well as families. Now this is important, it's very important, but as the Zimmerman and Mercier article that you were assigned for this week's module shows you, it's very important to take a systems approach and sort of have a wider lens toward prevention activities and develop strategies at the community and population level. With that being said, we will first focus on some of the evidence-based education programs that are focused on families, parents and caregivers, and in some cases even children. There are many forms of media, both interactive and just simple video media, that is often shown to expectant parents, new caregivers, to kind of prep them for some of the frustrations that can happen with being a parent or caregiver, some of the ways that you can interact and deal with some of the most common issues that arise. And a lot of times these are given in official educational settings where they're sort of like graded, and you eventually graduate and get a certificate after completing a test that shows that you've completed this program. And a lot of these programs do actually work pretty well. Parental education and support groups are starting to become more common as well. These often include structured parent-child interactions where you engage in a support group. There's some sort of professional counseling staff there that can observe some parent-child interactions within a safe, controlled environment, possibly through a two-way mirror or some such operation like that. And if problematic interactions are observed, then they can be like a call timeout and like have a quick instructional moment there on how to better deal with a certain situation. And so parental education and support groups, they're resource intensive, and the sad truth is that most of the parents and caregivers that most need them either won't have the means to seek them out or just will not seek them out. Sometimes educational campaigns and programs are directed at children themselves. As you would imagine, can be very controversial, to teach children about how to prevent assaults or other forms of abuse from occurring to them. You can educate children on physical and sexual abuse, teach them how to avoid risky situations, and how to respond if they suspect they are being abused. And you can see why this is something that we're all reluctant to do, because children do not have very much control over their environments, and they're young, and the attention really should be given to the parents, caregivers, other adults in the life of the child, and just greater society. That's where the prevention should be focused if we were in a perfect world, because they're the people that have a lot more control over the environment that the child is in than the child themselves. And as we'll talk about shortly, the training, this types of education for children themselves can actually be very triggering as well. So it's there are some evidence-based programs that do work, but they're very controversial. One thing that they do well, these types of prevention programs aimed at children, is they give children skills on how to avoid and minimize the risk, and they give children language tools and procedures to access help. What unfortunately happens a lot of times, particularly in the case of sexual abuse, is that children don't really have the language to describe to someone to a concerned adult who can get them help as to what has been happening to them. So this can help provide those language tools and maybe make accessing help a little bit easier. But again, the training itself for children can be very scary. It can be very triggering. And in very extremely limited circumstances, it can lead to false reporting. There was a phenomenon in the 1990s known as repressed memories, and that was where a situation where, in an effort to sort of ask children some questions about whether they had been physically or sexually abused by certain caregivers, the way that the interviewers were wording the questions and sort of the rapport that they had with the children wanted to give the interviewers the answers they thought they wanted. And so there were some very limited cases of children reporting abuse that actually did not occur once a full investigation was done. And don't get me wrong, this is incredibly rare. Usually, if a child feels discomfort and reports discomfort or that they've been abused, there's a legitimate reason for that. But still, when you try to educate children themselves, this is one of the risks that you run, along with the fact that the training is very scary and triggering. And as public health minded people, we should not put the onus on children to protect themselves from this type of abusive behavior. The onus should be on the greater society to protect children. One evidence-based strategy that works really well, not just for prevention of child abuse and neglect, but also for prevention of other adverse childhood experiences, would be early home visitation. This is where new parents of infants and young children are visited by a healthcare professional, by a skilled nursing staff, by somebody who's like an expert in child rearing, just actually comes into their home and provides education regarding infant health and development, about how to model positive adult-child interactions, how to provide social support, and just assisting parents in achieving life outcomes, such as if a parent or caregiver wants to pursue their education, somebody you can talk to them about realistic ways that can occur while you're raising a child, because there are a lot of programs now that are designed more for working and caregiving professionals than there maybe used to be back in previous decades. So even though the evidence base is very strong, for these early home visitation programs, reducing the bad things that we're trying to reduce. The one obvious weakness of these programs is that the visitation only lasts a short period of time, and then there's a phenomenon of what we in epidemiology call the Hawthorne effect of sometimes just by observing behavior, you change behavior. That just by people knowing they're being watched and observed by somebody that's come here to look at their behavior, that you don't necessarily always get the same of what they would do if you were not there. I mean, but in epidemiology and social sciences and cohort studies, that's just something we have to deal with. But the evidence is still very strong that these programs do work. What's probably just as important, maybe even more important than individual and household level efforts, are to sort of widen the lens and do community level efforts and partnerships to try to encourage a community to sort of consider their children as a whole and encourage multiple entities to work together and protect children and support families. What's been consistently shown is that when people live in a community or they have an employer that seems to send the message that children are important and that families are important and that familial stability and safety is important and being a safe community for children is important, that makes a huge difference. That reduces the number of adverse childhood experiences. Whereas when people are in communities where they feel isolated and like nobody is there to help and nobody cares, that greatly increases the likelihood of adverse childhood experiences. As was discussed also when I talked about community level ACEs and how some of the more recent ACE studies include community level factors, I mean, this can make a big difference in whether a child has a sense of safety and security or not. You know, children can perceive if their neighborhood is dangerous, if they can trust their neighbors or not, and that the converse is true as well. And it can be so working with an entire community and forming partnerships where everybody is in agreement about certain desirable outcomes can make a difference. What's also important is public awareness efforts, these kind of campaigns that are done to mobilize the public and influence societal beliefs about parenting and abuse and kind of readjust social norms. This can help create a safer, more nurturing environment for all children that are in the sphere of influence for these public awareness efforts. A vivid example of that happened several years back now, and there was a very famous running back in the National Football League who had a 4-year-old son. He did not have sole custody of his 4-year-old son. In fact, he had very intermittent custody of this 4-year-old. And after a weekend of being with his dad, this 4-year-old went back to his mom with several welts on his backside from where it looked like he had been beaten with a stick. And then the father admitted in interviews that yeah, he had tried to correct his son's behavior. His son had done some things that this dad thought was not appropriate for a 4-year-old to be doing, and so he thought the form of corrective action that was called for was corporal punishment, in this case with a stick or a switch. There was a lot of backlash at the time too. A lot of dialogue about whether or not society has moved past the need for this type of physical punishment to be exerted on a child, particularly a 4-year-old child. I mean, 4-year-olds are not going to have the same developed sense of right and wrong, the same developed conscience of a much older child, and so the player wound up getting suspended from the league for several weeks and fined several $100,000, and there was a big chance to sort of reset social norms around corporal punishment and other forms of physical punishment, particularly among very small children. So these are examples of social norms campaigns and public awareness efforts that have actually created a safer environment for children. Let's return now to that Zimmerman and Mercy article that you were assigned in this week's module. There's a really interesting and important table in that article that compares reactive versus proactive approaches to prevention of child maltreatment. And as you'll see, a lot of our prevention strategies have maybe been a little too reactive in previous decades, and there is more proactive, sort of wider, systems-based thinking that needs to happen. And these are just some examples of sort of what it was and probably where it needs to go. So if the question is, what is the problem when we have children being maltreated? The reactive approach would say that it's poor parenting, that we need to go and educate parents, and if parents cannot be educated, they need to be either incarcerated or have the children taken away. A more proactive approach would say that it's a lack of formal or informal societal support of parents and a lack of access to new information that's the problem. And if we address those things more upstream, there will be greatly reduced rates of child maltreatment. If the question is, what created this problem? The reactive approach would say that it's upbringing, that it's substance abuse, that it's just parents making bad choices. Whereas a more proactive approach would be real about the problem and say that it's being part of a society with short-term vision where children are treated as nuisances or as sort of impediments to maximal societal productivity, outdated theories on raising children, such as the idea that 4-year-olds would respond well to physical discipline by a form of a stick, and also declining communities. When people don't feel safe or supported in their communities and feel isolated, then that's child maltreatment is more likely to occur. So that maybe that's what we should be focusing on. In terms of what solves it, the reactive approach would say that it's parents fixing themselves, that it's the foster parent system, that it's child protective services, and the police getting involved in the case of the worst forms of abuse. And while all those are always going to be necessary, a more proactive approach would also include having community leaders with a vision, making sure that friends and neighbors are involved, not just with each other's kids, to the degree that it's safe to do so, and along with healthcare systems, faith groups, doctors, schools, and others. So again, we can be a lot more proactive in our approaches to prevention of child maltreatment if we just choose to be. Ultimately, the most successful public health strategies for prevention of child abuse, neglect, and maltreatment would weave together programs, policies, and people. And in doing so, we would do things such as change social norms, encourage community actions, educate the public. Education is always going to be an important part of any of this sort of public health. That will probably never change. It always needs to be, the education needs to keep evolving, but yeah, education is still very important. And then advancing policies that support families and that value young children, that show that raising children is important in its own right, and the society does not feel like it's a burden. One of the most important things that we could do here in the United States that we just haven't really done to any appreciable degree is to have like generous parental leave policies at workplaces. They're trying to encourage people after they've had a child to come back to work as soon as possible really does not send the kind of message that we want to send about the value that our society puts on children and on parent and caregiver and children bonding and on just building a healthy society for the next generation. And we need to maybe do better at that. So again, even though education will always be important, sort of shifting our focus away a little bit from just individual level education to parents and caregivers about what to do and what not to do when trying to raise a child. Though it's important, going a little bit wider is going to be much more important and is going to actually create the society that we want. The Zimmerman and Mercy article brought up an example of this from smoking. Quitting smoking is not an easy thing to do, but people know how to quit smoking now. Whether they actually can follow through with it or not is a different matter. I mean, there's enough educational materials and enough like support groups and support activities for individual level action. If one person wants to stop smoking cigarettes, there are tools, including gums, support programs, everything else available to them to help them with that. But what our society has done is we've actually changed the whole entire environment around smoking. And that has probably done more than anything to reduce smoking and smoking related diseases. You pretty much cannot smoke indoors in most establishments anymore. That because people have a right not to be exposed to secondhand smoke. 40 or 50 years ago, it would have been unimaginable or very exotic to think that indoor smoking would mostly be banned everywhere outside of, for example, casinos. But it has been. And cigarettes, the cost of cigarettes now more carefully reflects their cost to society because cigarette taxes are much higher now than they used to be and some of the money collected by cigarette taxes is actually used on smoking prevention programs and on cessation programs and on trying to counteract some of the public health damage done by smoking. So we've kind of gone much wider than just educating people on how to quit smoking and have had a dramatic improvement in smoking rates and just societal and social norms around smoking. We can do the same thing with child abuse and maltreatment if we just have the will to do so. The Zimmerman and Mercy article highlighted probably one of the more effective prevention programs that's been developed for prevention of child abuse, neglect, and maltreatment, and that's the Nurse Family Partnership and Home Visiting Study. This was started back in 1977 in Elmira, New York. It just started with a group of registered nurses making home visits to young, first-time, low-income mothers over the first 2 years following the birth of their child. And since then, this program, because it's been so successful, has been expanded to 25 states, and it's still going to this day. There's still people running basically the same program that was started in 1977 to the present day. And there have been well over 20,000 families visited in all the different states where this has been adopted. But what's been consistently found with this program, both the original and the subsequent versions, is that it improved parental health. It reduced childhood injuries. That there were fewer subsequent pregnancies among people who had these home visits from a registered nurse versus control groups, families that did not have visits. There was increased maternal employment. It was found after this initial cohort in 1977 that 15 years later, upon follow-up, there had been a 48% reduction in child abuse and neglect in the families that had participated in this program versus control families that had not participated. And so home visit programs are now recognized as a very effective child maltreatment prevention strategy. There's a version of it right here in Clark County, Nevada, and it's very effective. And my hope is that it will continue to be funded and will continue to grow, and its reach will grow so that everybody that needs this will get this. Children are more vulnerable at some stages of life than others to abuse and injury. And one of the most vulnerable times in a child's life is infancy. This is when an infant tends to cry a lot. And especially if you have a parent that doesn't know how to deal with a crying infant, this sometimes leads to what we call shaken baby syndrome, and that's exactly what it sounds like. It means that it's sort of a maladaptive way that sometimes parents and caregivers will respond to a baby that won't seem to calm down, and they can't figure out how to make them stop crying. Well, of course, shaking a baby is one of the worst things you can do. It can cause severe neurological injuries, and even death. And so there's a huge effort in many jurisdictions to try to prevent shaken baby syndrome from occurring. And one of the pioneering studies of this occurred in North Carolina, this initiative called the Purple Crying Initiative to prevent shaken baby syndrome. What this program did was provided parents information at birth about crying, about why infants cry, how you can respond to it, how you can sort of check your own emotions, because it can affect your own emotions as well when you have a persistently crying child. How to not necessarily ignore the crying, but to sort of have a more positive reaction to it. And then the lessons that are provided to parents and caregivers are reinforced through routine well baby visits, sort of like what we talked about before with the home visiting program, where you have an expert come into your house, do a well baby visit, talk about conditions. You can be real about some struggles and things like that. This initiative has been shown to be very effective. Many other states have adopted it, including Nevada. Here in Nevada, there's an organization called Prevent Child Abuse Nevada that has brought the Purple Crying initiatives to the state. And a lot of these are actually done right here at UNLV and by researchers with the Nevada Institute for Children's Research and Policy, which is housed in the School of Public Health here at UNLV. Another program came from Australia, the Triple P Positive Parenting Program. It was started in Australia, but it's come to the United States and several other countries since then. It promotes positive parenting and reduces child behavioral problems through different tiers of established evidence-based programming that are at 5 different levels of intensity. In this case, the parents, along with some input from researchers and other professionals, determine what level of intensity is needed for each, depending on the family and the circumstances. These levels of intensity range from media-based social marketing campaigns at the one level, all the way to individual consultation and sort of like the equivalent of well baby visits at the highest level. These have been shown to be incredibly effective. The issue with these sorts of programs is they require staffing, and so it needs to always be a supply of well-trained, caring people who can staff these roles, and they should not be subject to budget cuts. We will now move to the other end of the life cycle of vulnerable populations and talk about the problem of elder abuse. This is an issue that will only get more significant in the United States over time because the current estimates from the U.S. Census Bureau is that by the year 2034, the population of people greater than or equal to the age 65 will outnumber the population under the age of 18. It's what's known as the graying of America, and that's why we need to address these issues of elder abuse and exploitation now before it becomes an even greater problem. The U.S. Administration on Aging defines elder abuse as any knowing, intentional, or negligent act by a caregiver or any other person that causes harm or a serious risk of harm to a vulnerable adult. Elder abuse can take many different forms, such as physical abuse, the actual infliction of physical pain or injury upon a vulnerable senior citizen by slapping, bruising, or restraining by physical or chemical means. Sexual abuse, which is non-consensual sexual contact of any kind. This includes when a senior citizen cannot give clear consent because they're in moderate to advanced stages of dementia. Neglect. This is where, instead of doing something, it's the failure to do something, the failure by those responsible to provide food, shelter, health care, or protection for a vulnerable elder. Another form is emotional abuse, the infliction of mental pain, anguish, or distress on an elder person. This can be done through verbal or nonverbal acts, for example, humiliating, intimidating, or threatening. Exploitation is defined as the illegal taking, misuse, or concealment of funds, property, or assets belonging to a senior citizen for someone else's benefit. And somewhat analogous to that is financial abuse, which is the most common form of abuse suffered by seniors in the United States. This is malevolent control over access to financial resources, which diminishes the victim's capacity to support themselves and forces them to depend on the perpetrator financially. Other forms of abuse are abandonment, where a vulnerable elder is deserted by someone who has assumed the responsibility of care or custody of that person, and self-neglect, which means that the senior citizen they fail to perform essential self-care tasks, and that failure threatens their own health or safety. Again, these definitions come from the U.S. Administration on Aging. One of your assigned readings this week was the Acierno and colleagues article spelling out their national elder mistreatment study that was conducted and published back in 2010. There were a total of 5,777 senior citizen subjects in this study. In the confidential polling of these subjects, it was found that 4.6% of them had reported suffering emotional abuse. Of those that had suffered emotional abuse, only a little under 8% of them had reported this emotional abuse to the police or some authorities that could handle this, that could take care of the situation. About 92% did not. 1.6% of the subjects had suffered physical abuse, and of those who had, only 31% had reported it. 0.6% of these subjects had suffered sexual abuse, and only 16% of those who had suffered this had reported it. Just a little over 5% of these subjects had reported neglect, and 5.2% reported financial abuse. This is consistent with some other studies that show that usually the most prevalent form of abuse among senior citizen vulnerable populations is financial abuse. When Acierno and colleagues looked at the risk factors for mistreatment among the 5,777 subjects, they found that major risk factors included being in a shared living situation, or being socially isolated. Both of those were actually risk factors for increased risk of mistreatment. Dementia, depression, substance abuse, having a situation where an abuser is dependent on a victim, particularly financially, greatly increased the risk factors for mistreatment. Health and functional status were inversely correlated, meaning that as health status went down and functional status went down, the risk of mistreatment went up. There were also some demographic risks for potential neglect, that subjects who were in poor health, were non-white, and were of low income and had low levels of social support were at increased risk for potential neglect. One very interesting finding is that the young old, meaning subjects who were less than 70 years old but over 65, were at an increased risk for physical, emotional, and financial abuse. And this might have been due to underrepresentation of institutionalized adults in the study sample, or maybe just it was due to selectively greater representation in the sample among the young old, just because they might be more able to respond to a research study. But regardless, that was an interesting finding. And across all demographic strata, what was found is those with low social support were at increased risk for all abuse. If you didn't have a network of friends and family who regularly checked on you, particularly if you're in an institutional setting, that greatly increased your risk for every form of abuse. The American Association for Retired Persons, or AARP, has a public policy institute. Among many of the things that they advocate for is trying to let people know where their state ranks in terms of the type of long-term care services and support that you can count on in your state. And they do this by what's called the scorecard. And here's the state scorecard from 2023. What you can just see from looking at the colors is that Nevada is not doing particularly well. Nevada is in what's called Tier 4, meaning the second to worst of all the tiers. So that in terms of some of the, and we'll get into the specifics in the next slide, but yeah, Nevada, Wyoming, and South Dakota, and then much of the southeastern United States are all kind of at the bottom when it comes to their overall performance in long-term services and support across 5 critical dimensions. So here's some of that specific data for Nevada in detail. What we see is that in 2023 scorecard, Nevada ranked 44th out of 50. So that's at the very end of Tier 4 and almost to Tier 5. And there's not a lot of states ranked below Nevada. The reasons for the low ranking include affordability and access to long-term care. Nevada ranks 49th. Ranks 48th in choice of setting and provider. Ranks 48th in terms of the safety and quality of long-term care and services and support provided to people who need them. Where's Nevada doing a little bit better? Well, we can see that Nevada ranks 33rd out of 50 in community integration. Community integration is a key step that's overlooked in a lot of states, where when people are transitioning out of the home they maybe have lived in for most of their lifetime into a more skilled care facility because their circumstances necessitate that, there's a lot of integration and sort of transition that needs to take place to make that safe and effective and to make sure that people actually wind up in safe places. And so Nevada ranks a little bit better than some of the other rankings in that, but still 33rd. They could do better. Nevada is doing a relatively good job in providing support for family caregivers. They rank 19th out of 50. But when you add up the total scores, Nevada is 44th, the very bottom of Tier 4. Only some states in the southeast rank lower, so much room for improvement. Another study by Schiomberg and colleagues, published back in 2012, looking at nursing home and skilled care facilities, found that almost a quarter, 24% of respondents in this survey, reported at least one event of physical abuse from nursing home staff. So again, almost a quarter of all respondents. That's a pretty high number. One way that several states, including Nevada, try to improve conditions within these nursing and skilled care facilities is to mandate certain levels of staffing. Now, obviously, the staff have to be trained and they have to be kind and not have malevolent intentions, but starting with More staffing usually equals more accountability. And here in the state of Nevada, Nevada Revised Statute 449-0117 spells out some of these staffing requirements for a nursing and skilled care facility. If it's a facility with more than 20 residents, it has to have at least one awake staff member at all times, and there needs to be an additional person available within 10 minutes. They can be somebody on site that's like taking a nap or somebody who lives nearby, but they have to be available within 10 minutes without exception. For all facilities licensed for 20 to 49 residents, they must have one staff member designated to organize, conduct, and evaluate all activities that take place within the facility. And if a facility is licensed for 50 or more beds and 50 or more residents, they must have a full-time person for activities. One very important federal act was passed in 1965, and that's the Older Americans Act. This established the U.S. Administration on Aging, and the federal agency which was empowered to sort of promulgate the regulations of the Older Americans Act. What the Older Americans Act does is it promotes the well-being of older individuals by providing services and programs that are designed to help the people live independently in their homes and communities. And then, of course, when the time comes where you maybe can't live in your own home anymore and you need to transition into a more advanced care facility, to make those transitions easier and better and more positive. The Older Americans Act empowers the federal government to distribute grants and funding to states for supportive services for individuals over the age of 60. Again, the whole purpose of the Older Americans Act and the grants that are given to states is just to ensure that as people get older, that the quality of life doesn't suffer like it can if there's none of these services and supports available. This is a time when we all become more vulnerable, and so if there are ways to sort of bolster this part of life, make the transitions easier, and make sure that the skilled care options are good and kind and meaningful and full of enriching activities, then that's really a public health benefit for all of society. Forms of prevention for elder abuse include screening programs where you very discreetly use interviews or direct observation of older persons and sometimes of the family members who might be the caregivers of older persons to identify potentially abusive situations, with the goal always being to predict the possibility of abuse before abuse occurs so that interventions can be targeted to situations where abuse is developing. And there are things you can look for if you're trained, red flags you might see in relational dynamics between family members and caregivers and older persons that can kind of give you an early warning sign that there might be some issues in that relationship that need to be dealt with before they devolve into abuse if they haven't already. Mandatory reporting is another form of prevention where, just like with child abuse, which we're going to talk about shortly, or with on-campus suspected sexual abuse, there are people who are mandatory reporters if they know or suspect that an abusive situation is occurring. This often includes, educational personnel, like teachers and professors. I'm a mandatory reporter, for example. Medical personnel, certainly. Religious personnel, such as clergy. They all have mandatory reporting duties under the Older Americans Act, just as they do for things like domestic and inter-partner violence and child abuse. Every state has adult protective services. That's something that's mandated by the federal government. And in order to receive federal funds, every state has to have these, and they have to be deemed to be effective through audit. With that being said, they vary from state to state. Some states have better adult protective services than others. Education of professionals is also critical. This increases the awareness of potential signs and symptoms. And again, this is kind of like mandatory reporting I talked about before, where there are certain behavioral indicators that often indicate that somebody is being abused. There are certainly physical indicators of abuse and neglect, such as scratches, bed sores, other things like that, where if professionals can be educated on what to look for and can catch it early on, then maybe the abuse can be stopped before it gets too far. There is a belief, and it's borne by evidence, that whenever the caregiver in charge of a senior citizen is under a lot of stress for various reasons, that greatly increases the risk of an abusive situation developing. So a lot of preventive strategies actually are caregiver support interventions that help reduce the risk of abuse taking place. Another thing that often happens is, as part of these caregiver support interventions, is working with the actual potential victim, the elderly person that's part of that pairing, giving them education so they can recognize some signs that maybe the caregiver's mental state and condition is not in a good place and that abuse could happen. Just basically showing people some signs and symptoms, providing awareness campaigns, and encouraging victims to report in the event that this relationship between the caregiver and the person they're giving care to does deteriorate in a way that leads to abuse. There's also legal and victim advocacy services offered for people who are prone to being abused. They kind of are similar to the models that are used for intimate partner violence prevention, in that some immediate social support is provided for the victim, along with tools for self-help, for extracting themselves out of a dangerous situation if it's possible for them to. Just like there are for intimate partner violence and domestic violence victims, there are safe houses and emergency shelters located in various places for elderly persons who are trying to escape abusive situations. And of course, training people on the legal actions that can be taken, that they don't have to put up with this. It's not ideal because a lot of times in this case the abuse has already started, but you combine all these things together, and if it's done right and if it's well funded and if people are aware of it, it can help prevent or mitigate some of the most severe forms of elder abuse. So my closing thought for this module is the following. With children and the elderly, we're talking about uniquely vulnerable populations. We're talking about populations that maybe don't have as much autonomy as people do in the middle years of their life. If we want to control and prevent injuries, yes, individual education does have a role. Certainly we can teach children some things. We can teach people in their senior golden years some things. But systemic changes at the wider level, at the community level and at the societal level, is always going to be necessary here because, again, you're talking about two populations that might not have the same degree of autonomy and agency that people in the middle of their life do. And so it's a little bit more important to support community level efforts to create nurturing environments for children and for senior citizens, and of course just improve society in some ways that makes for safer environments as well and gives caregivers at both ends of the age spectrum some of the resources and help that they need. That's it for this week. Let me know if you have any questions or comments. Thanks for your attention today.